The hearing of the Subcommittee on Health will reconvene, and I apologize. What did I say? We'd be back in half an hour? I obviously misjudged that. Hopefully we'll have some time now, though. And our next member for questions is the gentlewoman from Illinois, Ms. Schakowsky.
Thank you, Mr. Chairman. I regret that I didn't hear all the testimony, but I am quite familiar with both Dr. Wolf and Dr. Woolhandler, and I also want to refer a bit to Dr. Goodman's testimony, which has been told to me. I'm a supporter of single payer, something that's been used to sort of beat me over the head, because I understand that I believe that the compromise that we have, that the president and the draft bill endorses, is something that I endorse as well, because I think that it is an important beginning to controlling costs and to providing good service. But I do find it pretty ironic when I say beaten over the head. I'm talking really about the other side of the aisle, and people who, I can't quite figure it out, find that it's quite all right, and I don't know what the public interest rationale is to defend the private insurance industry, which has had their way with us for all these years, and without much accountability, and gotten us into this mess, and why those of us who are single-payer advocates who are willing to compromise, but the other side who are all for just the insurance industry are not, talking about giving Americans a choice. And I find it not very collegial, and certainly not in the best interest of providing health care to all Americans, which after all is the goal of the exercise, not to figure out how we can prop up the private insurance industry. Those of us who have agreed to the compromise think that they ought to be able to compete, but that is not the principal goal here. And we're willing to set up a situation where it's, maybe it's easy enough for them to do, but not if they continue to do what they've been doing. They're going to clearly have to change their ways in order to compete. I'm really sorry, I guess, I'm not, about that, but that's the reality. I was just talking to a representative of Cook County Hospital, Dr. Goodman, who was telling me that in Cook County Hospital, which is our public hospital, the wait for for colonoscopies, hip replacements, and certain gynecological services is up to 2 years. So let's be clear that there are certainly people waiting in line now. And I have to tell you, my understanding is, you can correct me if I'm wrong, that you said if you compare white patients in the United States to white patients in Canada, the outcomes are the same. But if you compare minority patients to Aborigines, we're doing better. Oh my God. I cannot believe that you said that in a public hearing. We are all Americans, and to somehow separate out those minorities and compare them to Aborigines as opposed to white Americans, minority Americans, all Americans, Canadians, etc., that would be reasonable. The other comparisons are offensive. And I don't know if you want to comment on that or defend yourself on that.
I'm not sure you heard my testimony. I said we have access problems, and there have been lots of studies that show that these
Did you make that comparison, though?
These problems are more severe for minorities in the United States than the white population. But it's also true in Canada. It's also true in New Zealand. It's also true in Australia. And if you compare our progress to theirs, we're ahead of them. We're doing better than they're doing. Okay.
Well, let me ask about this. Dr. Wolf and Dr. Woolhandler. Dr. Goodman has testified that again, if you compare whites to whites, that it's about even. But I wondered if you could actually talk to us about how we're doing compared internationally to other countries that actually do provide health care for all of their citizens.
Well, in my testimony, I referred to what percentage of people in the 30 OECD countries have insurance. And as I said, for 27 of the 30, it was over 96%. But in the same report, which just came out a few months ago, they also asked the question, how many people in various countries have an unmet care need? And that's sort of what you're talking about. Unmet care need was defined as unfilled prescriptions or missed medications, medical problem, didn't visit a doctor, missed tests, treatment, or follow-up. And here, the comparisons are really striking. In the United States, for people who were below average income, over half of them had an unmet care problem, 52%, whereas in Canada, it was 18%, just about a third as much. And even for the people with that was below average income. For people with above average income, again, it was about 3 times more likely in the United States to have an unmet care problem than when you look at these 7 countries.
Wait, can I just ask you? Yeah. So what you found contradicts what Dr. Goodman just said.
Well, it's not what
we're actually doing better. No.
That's
what
right.
The data
OECD, and this is generally agreed upon. I mean, the United States is one of 30 countries that belongs to it. They produce very interesting data, not only on health but other measures, and they put this out frequently. And these are valid comparisons, interesting, and they really go against what Dr. Goodman said earlier, a couple hours ago, that there are more access problems here. There are more access problems in other countries than here. There are more access problems whether you're above average income or below average income in the United States than in other countries. And obviously one of the reasons is that people are all insured and they don't get thrown out of emergency rooms as people frequently do in the United States, violating the patient dumping law.
We're going to have to move on. If that's okay, because it's a minute and a half.
To Congressman Malone.
Mr. Shimkus, thank you.
Mr. Chairman, can I defer and come back in the next Republican round so I can listen to, can I just defer who's ever next on the list?
Oh, you want Mr. Shadegg to go first? Sure. Mr. Shadegg.
Thank you, Mr. Chairman. Mr. Goodman, do you agree with the statement of Mr. Wolf that there are frequent violations of the laws requiring the treatment of patients at hospital emergency rooms in the United States, and are you aware of any studies that show that?
I'm not, but
I don't think your microphone's on.
No, I'm not, but I do concede we have an access problem, and I think the waiting in hospital emergency rooms in this country is atrocious. We had in Dallas a man who waited 19 hours and died before he ever got care. So I don't know if any law was violated, but I don't think that should be happening.
If I can respond,
I would agree. I'm sorry, my time's limited. I would agree with that.
Okay.
Can you tell me, since he challenged you on the point made earlier, would you reiterate the point made earlier and explain to me, or contrast for me, waiting times or waiting periods in the United States under the current system versus those experienced in England or Canada?
Well, see, what I think is happening at our hospital emergency rooms is exactly what happens in Toronto and exactly what happens in London. I mean, we're rationing care here just like they ration care in other countries. And to talk about everybody having access to care just because they're on paper insured is nonsense. The reality is that lots of people aren't getting care they need when they need it in a timely way around the world. And I think that if you look at the data, we do a reasonable job with a heterogeneous population compared to other countries. We could do a lot better, but let's not pretend that they're way ahead of us, because they're not.
Let me make a statement. I am unaware of waiting periods in the United States at any facility, emergency room or otherwise, of months. And I am very much aware of waiting periods in Canada for various procedures that go more than a month. That's not a question. That's my statement. What is your suggestion, or what would you do, as opposed to, I presume you do not favor a public plan?
No, I don't.
Okay. What would you suggest we do rather than moving to a public plan?
I think we ought to focus on the problem we began with, and that is the uninsured. What should we be doing for them? Right now, if they buy their own insurance, they get no tax relief whatsoever. Right now, if your employer is not allowed to buy for you insurance that you can take with you when you leave the place of employment. It's illegal in every state to buy personal and portable insurance, which is the only kind of insurance that people could take with them in and out of the labor market and from job to job. Those are just a few ideas.
You're familiar with the legislation I introduced that would allow individuals to buy health insurance that was qualified under a federal law and then written to comply with one state's law and then be sold in multiple states?
I am, and I think that's a good idea.
And would that bring down the cost of insurance?
I think it would.
And would that reduce the number of unemployed or uninsured?
I think it would.
Okay. What would be the best mechanism, you think, for making health insurance portable for those Americans who do not have health insurance? And would it include a refundable tax credit, as I have proposed, and others such as Congressman Ryan and Senator Coburn?
Yeah, the Coburn bill is a wonderful bill. But even without going that far, we need to give tax relief to people who buy their own insurance. We need to allow employers to buy the kind of insurance that people can take with them and is individually and personally owned. And we need to get rid of a lot of these state regulations which force up the price of insurance and price way too many people out of the market.
That last point is exactly what we were doing with my legislation that would let you buy a policy essentially filed in one state and then sold in the other 49?
That would be the practical effect of it, yes.
It would be the practical effect of reducing those mandates and thereby bringing down the cost of health insurance?
That's right.
You and I have talked about refundable tax credits and about the outrage of a current American law which says that if you get health insurance through your employer, it's pre-tax, but if you buy it on your own, it's taxed. We've been talking about that for how many years now, John?
Oh, at least 2 decades.
It seems to
it's
me
just
that
as bad now as it was 2 decades ago.
if we just changed that law and said we're going to allow all Americans who want to buy health insurance to do so on the same tax-favored basis as businesses can do, that would create dramatically more competition in the health insurance industry, wouldn't it?
Well, but more importantly, it would allow people who are on their own to have tax relief, and it would encourage them to buy insurance, which they're not now buying.
If we coupled that with a refundable tax credit for those who can't afford health insurance, which is what I would propose doing, we would both bring down the cost of health insurance for all Americans and drive up quality, would we not?
That would be the most important thing, most important change in the healthcare system. Give every American a refundable tax credit. Let it be the same for everybody. And in the latest Coburn bill, I think it's $5,700 for a family. So the first $5,700 is effectively paid for by the government for everybody, and then additional insurance comes after tax out of our own pockets. It would radically change the kind of insurance we have. It would change everyone's incentives. Nothing would that I can think of that's been proposed recently would have a bigger impact on the healthcare system.
Yeah, the Republican proposed refundable refundable tax credit for health care has been on the table for years by senators like Senator Tom Coburn and I, who have been advocating it. That would have solved the problem of America's uninsured a long time ago, would it not?
Well, it would go a long way toward it.
Thank you very much.
Yes.
I thank you, Mr. Chairman, for your indulgence.
Sure. Mr. Wiener.
Thank you, Mr. Chairman. Is there consensus of the three of you on the panel that the administrative cost for private insurance plans is much higher than what it is for the Medicare system? Why don't we start with you, Mr. Goodman? Is there any question the administrative?
There probably isn't a consensus here because the statistics that you heard earlier count the private insurers' cost of collecting premiums, but they ignore the government's cost of raising taxes. And if you want to make a fair comparison, you have to compare apples with apples and oranges with oranges.
So the administrative cost, you mean the IRS?
Yes.
You think the IRS, if you back out the IRS for the purpose of this conversation, is there, then it's obvious, is there any disagreement that the Medicare system is much more administratively efficient than private insurance?
Well, if you mean by backing out the IRS, we ignore the cost of getting public funds, but we count the cost of getting private funds, then yes, the Medicare would be cheaper.
Gotcha. And is there anything that we can learn from how Medicare does things administratively? Is there an obvious place that we can that efficiency is found? Dr. Woolhandler, do you have a sense of, is there something in that? I mean, I know, for example, that insurance companies benefit to some degree monetarily from delays and inertia, right? If they don't pay, for example, reimburse a doctor or hospital for a 30 or 60-day period of time, they make money on the money that they're not allocating. There are things like that. But are there other elements that we can learn if we wanted to teach the private insurance companies, which is what President Obama said the other day at his press conference, that he thought it might be instructive for the private guys to copy some of the things that the public model does. Is there any one or two things that jumps out at you that make Medicare more efficient?
There's a lot of things, but you can't transplant them to private insurance because private insurance makes their money by not paying the bill, by collecting lots of premiums and not paying. So there's lots of expenses they have that are essential to their competitive strategy. So they want to be very, very careful to recruit healthy people.
No, I understand that, but you're answering a different question. I understand they're not going to want to do it. I'm asking you if you were to say, here's 2 or 3 things that Medicare does that they do more efficiently than private insurance, like are there a couple that may come to mind that might inform the committee's deliberations here?
Well, I mean, Medicare is universal, and it does use the IRS to collect money and the Social Security system, which is a very efficient way to do it because those things exist already anyway, and they're not going to disappear or get any bigger
So that their
or smaller.
billing apparatus is much more efficient.
The collecting of the equivalent of premiums is much more efficient. Also, Medicare doesn't do any cherry picking. They don't try to attract healthy people and keep sick people out. They can't. It would be illegal. They take everyone. So they don't have any of that so-called marketing expenses, which is really about recruiting healthy people and keeping sick people out.
Dr. Wolf, let me ask you this question. Dr. Goodman, feel free to weigh in when he's done. The argument made against single payer, and I don't know how persuasive it is, and frankly, I plan on offering single payer as an option here when we mark up the bill, but the argument that is made is there are a lot of people for whom their present insurance plan is satisfactory. They say that they're satisfied with it, they like the doctor relationship, they don't mind getting the bills, they like what they've chosen. And a political argument is made, essentially says, when you're trying to do something this big and this difficult, pursue what Dr. Goodman has been pushing us towards, try to solve the problem without creating the big tumult around people who don't generally perceive there to be a problem. That's a pretty persuasive argument on a political level. I mean, to say to 120, 130, 140 million people, we're not going to touch your thing that you have. How do you respond as an advocate for single payer for the idea that while it might be more efficient for the reasons you stated in your testimony, we may be permitting the perfect to be the enemy of the good by creating an untenable political dynamic? Why don't you give us your response for that?
I think the main response is that people would be concerned if you thought they were going to disrupt the relationship they had with their doctor, with their dentist, with their physical therapist, with their hospital. And the single payer is looking only at how the money is collected and how the bills are paid. There's no reason why anyone who's going to Dr. A would not be allowed to go to Dr. A if there was a single payer system. In fact, they might also want to go to Dr. B, who they would have liked to go before.
Because in your vision of the single payer, a doctor would be compelled to participate. Otherwise, they wouldn't be able to be a doctor in the United States because they'd be opting out of so many
Right.
patients.
I mean, in Canada and lots of other countries, if you're going to receive money for delivering medical care, you can't discriminate against this or that kind of patient. So that, if anything, the doctor-patient relationship would be enhanced instead of disrupted. A patient could go to a doctor that they couldn't have gone to before because that doctor wasn't in their pool. There's no such thing as your limited pool of doctors or hospitals, for that matter, you can go to. So in terms of the disruption is really a disruption of the health insurance industry, not of the doctors, not of the patients. I mean, the reason why 60% of the doctors in Massachusetts, in a study published a couple of years ago, support single payer is that they are getting sick and tired of spending so much time in their offices fighting with insurance companies to pay bills, hiring people that are not delivering medical care but are just sort of engaging in phone or email or fax wars. So I think that if the focus is the patient, then it is less disruptive.
Right. Well, I thank you, and my time has expired. I would just caution you, Dr. Wolf, that what you're answering is a substantive question, and mine was a political one. And someone who has Oxford, who then is going to go to a single payer, is going to lose their Oxford, whether they get the same doctor or not. That's the rhetorical challenge that we have as advocates for a better system. But I appreciate the candor of your answer. Thank you, Mr. Chairman.
Thank you. I'm just going to ask members, I know we each have 5 minutes, but, this is the first of 3 panels. just try to at least end your questions within the 5 minutes. I don't have a problem if the panelists answer go beyond the 5, but I want our questions or comments to end at the 5 minutes. Otherwise, we're going to be here till later 9 o'clock tonight. Next is Mr. Deal. Mr. Shimkus.
Thank you, Mr. Chairman. There's a couple ways that members could come to these hearings. This is a very important issue, and I think we all come in all the seriousness that we should. You know, first, just on this rush to move, I've talked about in the energy bill having a discussion draft that people can't really talk about because we know the discussion draft will not be the bill. It's not going to be it. So when we end up marking the bill, we're going to get a bill on a Friday, just like the energy bill, which will have 300 more pages that my staff will try to email me at home that they hope that I'll read and go over to be prepared for a markup. So this process is, healthcare is broken, this legislative process. Now we can do it in this committee. We did an FDA reform. We really did. Democrats worked with us. We compromised. We got a good bill. We got a bill that passed out on a voice vote. Major reform of the Food and Drug Administration. And I think people are, you know, you win some, you lose some. Overall, we're pretty happy. We didn't have that in energy, and we're going to have a Texas death match fight on the floor come Friday. We're not going to have it here. And so we're going to have another Texas death match fight whenever this moves to the floor. And it's just too important of an issue to do that. So I've always been struck by why don't we move increment? I mean, there's an incremental process, and people understand that. And call our bluff. Let's get insurance to more people. Let's try associated health plans. Let's try giving people tax incentives. Prove us wrong that a private system doesn't work, and then the public option might be the default. Maybe a one-payer might be default. I was in Chicago at the American Society of Plastics, and I talked to a legislative luncheon with some of my colleagues. One of the guys there, whose spouse was attending, sold medical technology, and he had just come back from Canada. This hospital was excited to buy their second MRI. And they're going to reduce their wait list from 8 months to 4 months for an MRI. I'm not making this up. We all know there's horror stories on both sides. So my plea is for us to try to move in a way that we can try to cover people before we bring what I believe is the heavy hand of government. Let me go to questions. Let's talk about this, Mr. Goodman first, and I'll let people chime in because I'm not really trying to incentivize one side or the other. Usually I do that, but let's talk about this Medicare thing, and let's address, every time politicians talk about saving the government money, what's the first thing off our lips? Waste, fraud, and abuse. And where do they point that this waste, fraud, and abuse is? Medicare and Medicaid. And my friend from New York talked about the cost of this. Shouldn't the cost of waste, fraud, and abuse be part of this calculation? If we're going to compare private insurance with government-backed product?
Well, it should be. And in my opinion, the thing that Dr. Woolhandler praises about Medicare and Medicaid is, in fact, one of its faults. They spend too little on administration. You ought to spend some resources watching where the dollars go. And apparently there's an enormous amount of fraud in Medicaid and Medicare. And you're not going to get rid of it if you don't spend some resources to find out where the dollars are going.
And the percentages of like 30% claims that are paying claims that shouldn't be paid. So 10%, I can't even read my notes anymore. But there is a credible cost. If you're going to claim you're going to save money on waste, fraud, and abuse, that it ought to go into, that would be good money. to go after, the return on the investment. Let me just finish with this, my time, and I want to be respectful to the chairman. The Massachusetts example, just recent release, what are they doing? They're going to raise their costs, they're going to cut services, they're going to reduce their beneficiaries. That was just announced today. What does it make us feel like that's not where we're going to be if we move into a one-payer system or a public option?
The one aspect of Massachusetts that is very prominent, and it's actually in this bill, in the Tri-Committee bill, that we haven't discussed much.
The draft language. There's no bill. A bill is a bill when you actually drop it and it gets a number.
The Tri-Committee draft includes an individual mandate, just like Massachusetts, which is, of course, what the private insurance industry wanted. They said that was their number one thing that they wanted was an individual mandate. And it's here in this bill called individual responsibility.
But the Massachusetts is cutting benefits, raising premiums, and cutting service.
Absolutely.
Okay.
Absolutely, because it's not affordable what they've done. And the individual mandate piece hasn't worked. It's been very punitive, and it's here in the Tri-Committee draft. And it's a complete gift to the private health insurance industry, just as it was in Massachusetts, because it's saying that the government is going to make it illegal not to buy private insurance. And that's actually something that needs to be discussed and is really totally caving into the insurance industry, no matter what else is in this bill.
Okay. Mr. Deal.
I'd like to follow up, Dr. Wolf, on something that you said about how your world of a single payer would work, and I believe you said it in response to an earlier question that in a single payer world, physicians would either be in the system accepting the payments that the system dictates that they are entitled to, or else they would not be able to practice, period. Is that correct?
Well, they can practice privately and collect money from patients. There's nothing to stop that. In the United Kingdom, the so-called Harley Street physicians are physicians who aren't part of the National Health Service. They practice, they have expensive practices, and patients can pay them. The only point I was making is that the Canadian system, which is called Medicare for everyone in the country, is one that if a physician wants to take care of patients who don't have money to go to a private doctor, then that physician needs to participate. The physicians in Canada actually make reasonably large amounts of money with the kinds of prices that are placed on the services by the government. So it is not, it's restrictive only to the sense that if someone really wants to practice medicine for someone other than a group of very wealthy people, they participate in the program. Again, they're in private practice.
Okay.
They are not working for the government. They're just getting paid by the government.
One of the concerns that we currently have is doctors who will not take Medicare patients simply because the reimbursement rates they consider not adequate. Under the proposal that we're looking at, the public option plan, as I understand it, keys reimbursements to Medicare reimbursement rates. Now, one of two things is going to happen. Either the public option plan is not going to be able to get any doctors to sign up to participate without coercion to do so, or the private plans are going to decide that the only way they can compete with the government is to ratchet down their reimbursements to the Medicare levels, and therefore the private insurance market providers are going to have the same complaints that they currently have in our Medicare reimbursement system. Dr. Goodman, maybe I could ask you to comment on that.
Well, I think you're exactly right, except I don't think it will be all one way or the other. With that kind of system, what we will gravitate to is a public system in which most people will be enrolled, and the doctors will be paid below market rates. And then there will be a private system, just as like they have in the United Kingdom, or some version of that. And anyone who has the money will buy better coverage, and they'll be seen first by the doctors, and they won't wait as long. And you know, Britain has a two-tier system, and what you're pointing toward would be a two-tier system for the United States.
Can I just respond briefly to that, which is, I mean, one of the reasons that we are opposed to this public-private option is that it does cause some of the exact things you're talking about. Why should it be that a given doctor should not get the same amount of money for seeing patient A versus patient B versus patient C versus patient D? In other words, what I'm saying is that under a single-payer system, the doctor could see any patient they wanted. The patient could go to any doctor they wanted without the fear that this doctor won't see them because they're not getting paid as much as they would be paid if they had some other insurance. I mean, it is bewildering to a doctor and their staff to have to look at a patient and say, do they have this plan or plan number 10 or plan number 20? And if they have that, does it cover this or that or whatever? It's just an unbelievably complicated matrix, as opposed to just saying, you go to the doctor, and wherever you are, or whoever you are, the doctor gets reimbursed the same amount. I think that kind of two-fold system that is possibly built into the draft bill that we're discussing isn't a good idea, but it's not the only reason the draft bill is not a good idea.
I think we agree on that last statement.
I just say, as a practicing physician in Massachusetts, not only do I take Medicare and welcome it, but essentially every doctor in the state of Massachusetts takes Medicare, and none of us are going to the poorhouse. So I know there's people who can command even higher payments than Medicare pays, but Medicare payment is generally compatible with a pretty good standard of living for the medical profession. So I wouldn't worry too much about that issue, personally, coming from Massachusetts.
Well, coming from Georgia, I can tell you firsthand that we are having physicians who will refuse to continue to treat long-term patients that they've had for many, many years when those patients become Medicare eligible, simply because of the reimbursement rates, and they consider them to be inadequate. And my state, at least, I think, is experiencing that kind of problem currently, and I just don't want us to see us magnify that problem. I believe my time is up. Thank you, Mr. Chairman.
Thank you. Dr. Burgess.
Thank you, Mr. Chairman. You had no choice but to come to me, and I appreciate the time. And just for the record, I always saw Medicare patients in my practice in Louisville, Texas, because my mother told me I had to. And it made it very simple to follow that rule. Dr. Goodman, Dr. Wolf testified just a moment ago that in Canada, the doctor-patient relationship is enhanced by having a single-payer system. Is that your opinion also?
No, it is not. I think in general, third-party payment undermines the doctor-patient relationship, and that the ideal relationship is for the patient to control the dollars. And that's why I've advocated for many years the health savings account. I would like to see patients control a third or fourth of all the dollars, and for chronic patients, they can control even more than that. And we're doing this in Medicaid, by the way. We have a cash and counseling pilot program underway in more than half the states where the Medicaid, homebound disabled, control their dollars. They can hire and fire the people who provide them with services. There's 98% satisfaction. Well, there isn't any health care system in the world where you get 98% satisfaction. So we know that health care can be more satisfying, and we can meet the needs of patients in a better way if we reduce the role of the third-party payer, whether it's government or private.
And I actually agree with that as well. And I've often wondered why we don't construct a system where it's possible for an individual to have more of a longitudinal relationship with their insurance company. If an insurance company or a Medicare system is a necessary evil, why would we not construct one where there is some sensitivity to the purchaser on the part of the seller, just like there would be in any other transaction? And we heard just a moment ago from the gentleman from New York about there being a policy versus a political question. I also wonder if the backdoor into the policy that's desired, which may be a single-payer system, is to not involve ourselves in political incrementalism at this point in order to achieve that desired goal. Dr. Wolf, I wonder do you see that as being part of the trajectory or part of the desired outcome of I realize it's not a bill, but the draft that we have in front of us this afternoon?
I think I alluded a little bit to this earlier, but I think that we now have essentially 44 years since the last health insurance was passed, Medicare and Medicaid, and many people hoped, and I think sincerely, that somehow during the 44 years we would incrementally be able to cover more people with health insurance, and it just hasn't happened. I mean, we have the same insurance companies, some new ones, there are more HMOs and so forth than there were back then, but I think the incrementalism just hasn't worked, and particularly compounded by the economic problems of the last year or two, things are getting tougher and tougher. I would expect that the number of uninsured will rapidly go over 50 million. It's close to that now if we had numbers from 2009. So I don't see, back to your question directly, I don't see anything in this draft bill, as we are taught to correctly talk. It is a draft bill, it is. I mean, there's a lot of distance between here and what is, if anything, and I say if anything, seriously, is going to actually come to the floor. But I don't think there's really anything in the draft bill that, to me, could be rationally viewed as a stalking horse, as a way towards a single payer. If anything, one could argue that it's a way away from a single payer, because if it is changed, comes to the floor with some form of a public partnership with the private, it's going to be so bad that, if anything, it will move away from a single payer rather than towards. So I don't see anything.
Like Ranking Member Deal, I do agree on that last point. Let me just ask you a question, because my time is going to run out. Now, there have been some allusions to Canada versus the United States, and my understanding, correct me if I'm wrong, the Canadian system their healthcare system is on a budget. Their parliament passes a budget every year, just as we do, and their healthcare expenses are going to be budgeted. Ours in this country, we have the largest single-payer healthcare system in the world. It's called Medicare and Medicaid. We don't budget for that. We just simply say, send us your bills, and we're going to pay them, and we'll draw down the federal treasury or expand the deficit in order to do that. Do you think we should look more at Canada's budgetary system as a way to controlling some of our costs in our public system, in our Medicare and Medicaid system?
Well, one of the advantages of having a single payer, single insurer collector of money, is that you can more easily do what is called in Canada global budgeting. And so for a given hospital, for instance, instead of counting every...
Yeah, but you've already got 50, if I may, you've already got 50%.
The gentleman...
Well, I'm saying, but they're not doing it.
Can I just ask Dr. Wolf to answer the question, and then, because the time is
expired. The answer to the question is, in Canada, global budgeting is a good idea. We could benefit from it here. I don't think that Medicare has been run as efficiently as it could be. The administrative costs are certainly low, and there have been some forms of price control on everything other than prescription drugs. I think we could learn from that, but Medicare has now been around for 44 years, and if anything, for a bunch of reasons, it's getting worse than it was at the beginning. So we need to go back to some of the original principles of Medicare.
Some of our distributional issues would become greater, though, with a place of budgetary constriction.
Dr. Burgess, you're a minute over. You can't ask any more questions. We got to move on.
We'll see you afterwards.
Thank you. Listen, let me thank all of you. We appreciate it, and I think it was a good discussion. Sorry that you were interrupted by so long with the votes.
They were important votes.
All right. Well, I don't know about that, but thank you. Let's ask the next panel to come forward, please.